So today, hips. We have heard a lot about hips, and I know that people are very lucky in hospital to have you, Paul. So probably today, and after John's talk recently, I'll go to talk about a different perspective. So title, Treating Hips Within the Military Population. Why? Obviously because I'm a hip expert. What sports medicine can learn from military medicine, and this was eye opener for me when I started to work within the Defence Medical Center in the UK, because we must keep open-minded and we can really learn from each other's expertise. So probably sports medicine and sports industry can learn from our experience. And the interdisciplinary approach and how it works in practice, because a lot of people, they ask me all the time, what is the difference between MTD and IDT? And sorry, yeah, I don't have any disclosures for this lecture. Um, you know the objective. I think that you went through all the previous letters. So this is where I work. I'm privileged to work here, and I feel really lucky to be able to work. And as you can see here, state-of-the-art facilities, fantastic building. But I have to say, it's not the buildings and the facilities that making the difference, but the people and the approaches and the methods we use. So today I will try to share with you, our expertise and see if you can use this in your practice, and hence we can improve our patients' outcomes. Can you spot the similarities here? Why sports medicine and military medicine? You can tell. We have an athlete here in the right, and we have a military personnel in the left. How similar they are. But believe me, it's not only the physical demands that they are going through, but the psychological and the mental demands that they both have in this culture of risk, as we call. But you know, quite often we discuss whether elite sport can cause harm to our hips and to our bodies. How compelling this career are for the hips of our soldiers, of our athletes. And no, I didn't come today here to speak to you about teamwork, because this was discussed many years ago and hundreds years ago from Henry Ford. But look at this in the right. A successful teamwork is a group of many hands and in one mind. This one mind the difference sometimes. So this is our model. We use the interdisciplinary model at the Defence Medical Rehabilitation Centre in the UK, and I will show you here how is our clinic setting. This is your typical clinic, our typical clinic, and you see we don't follow this lonely example where the patient, the athlete, the soldier will come and see the doctor. No, um, the patient is the center of the room, and they know that they will meet their consultant. Consultant in the UK is the senior physician, the physiotherapist, the rehabilitation instructor, the occupational therapist, podiatrist, and many more. So this is how we run the clinics. This is how we listen and understand the patients, and everyone asking different questions and add with their input. But also, we have the extensive interdisciplinary teams. And here you can see our ultrasound room, where I work here with Ed Sellon, who is our senior consultant radiologist from Oxford, and with the patient. The patient is part of our team, and we discuss in front of the patient what is the plan, the clinical issues, and then the radiologist will go to focus to his diagnostic part. So the extensive ITD includes more specialists, the surgeon, the biomechanist, the pain consultant, the mental health specialist. Why? Because we have such a significant issues with their psychological and mental health. And the vocational OT. What is the vocational OT? Very important occupational therapists that they deal with the jobs, the military or the high athletic jobs that they have. Why extensive IDT? Because one size fits all does not apply in modern medicine, in sports medicine and sports injuries. Now they will say, well, multidisciplinary teams, it's a tradition for sports. We do know, yes, both multidisciplinary and interdisciplinary teamwork is used in sport and in healthcare. And we do know that it's a successful approach, but there is a clear difference between the two approaches. And despite the fact there are differences, many researchers and practitioners use these terms interchangeably. And this is something I would like to discuss today, because indeed the interdisciplinary approach is such an important approach that could really influence the outcomes. Are there fundamental differences? There are. They are. In the multidisciplinary care, we know that the team does not emphasize an integrated approach to care, and these teams are unable to develop a cohesive plan care, as each team member of the team use their own expertise to develop individual care goals. For example, you will refer your patient to the podiatrist, let's say. The podiatrist will give them advice. They will go at home and they will implement these strategies, but you will not be familiar with what have happened. You will not be able to interact with them unless if you work in interdisciplinary teams. On the other hand, in the interdisciplinary teams, each team member of this team builds on each other expertise to achieve common and shared goals. So what is the approach? In the interdisciplinary teams, the participants will share goals. They will overlap the practice because we are learning, right? Rather than working on separate discipline-specific goals. The professionals involved in joint problem solving, working beyond their scope of practice now. The treatment goals can overlap, and we collaborate with other disciplines. That means that we have regular communication between the team members. My door is always open. The teams are coming here. We discuss what is the best, and then we decide together, and we decide together along with our patients, right? Now, the team is working very close, and we know that we achieve great outcomes. So again, each team member of the interdisciplinary team builds on each other expertise to achieve common shared goals. This is what we do today. We work together. You are learning from my expertise, and I do learn from your expertise attending these Tuesday lectures. In your organization, still chipping away at silos, over the years, what we achieve at DMRC is that we flattened the hierarchy. Nobody perceives that are better than anyone else. So we are learning and learning and learning. Of course, we follow best practices, not only everything theory and things that I discuss here and experience. We have our best practice guidelines that we update every single year. We have our helmets and indicators of evidence, because when we talk about sports injuries, we're usually driven by the evidence that is available out there, and luckily this is updated all the time. What we do to ensure that we're following the best practice of treatment, and what are our helmet of evidence. Are we doing things differently at the MRC? Do we approach hips differently? What are our helmets of evidence? We don't. We do what every good clinician does out there. So 4 simple practices. We follow consensus statements, and we're really, really lucky to now have many consensus statements to treating hips and treating groin. And we know that the last 4 years, we have amazing consensus statements that they help us a lot to implement great strategies, with the last one to be the one authored by Paul, and I'm very privileged to be to play a little part on this consensus. And also, as Paul mentioned, more recently, we just published the summary of the ESCA consensus statement on growing pain in adults. So consensus recommendations, RCTs, systematic reviews, as very good clinicians, and I know that in Aspetar you have the best clinicians ever. You know the weaknesses and the impairments of your patients, and you're very good on patients, listening patients' voices and more. Let us see things one by one. Consensus recommendations. In general, we look at all the four consensuses and they follow the recommendations. We focus the consensus recommendations from the International Hip-Related Pain Network in Zurich a few years ago. They came with 6 recommendations, as you know. Do we follow these recommendations? We do follow these recommendations, and this is what they came with. Patients with hip pain receive exercise-based treatment. They receive at least 3 months duration. Those they will undergo to hip surgery, they will have prehabilitation and post-rehabilitation. We check the reported outcomes, the physical and psychological impairments. Physical activity in sport is recommended, and patients' expectations extensively discussed, and we also follow set decision-making strategies, and our patients receive a lot of education. What we do for exercise-based treatment? So exercise is the main tool, and we target their impairments and dysfunctions. Now, for these patients that they have rehabilitation potential and room for improvement, sometimes this is enough to improve. For those they will not improve that they will need surgery later on, going for surgery with improved function and improved impairments, they will have better outcome. We know that exercise-based treatment has 3 months duration, and we do this, and we have seen the benefit of standardized protocol. So the good physiotherapy, the good rehabilitation, but also follow strictly 3 months durations. The patients are coming to us, we educate them, we show them how to do things for 2-3 weeks, and then they're going back home implementing these programs for these 3 months. When they're coming back with the IDT clinic, we check all the parameters, and we see that they're improving significantly. If we don't have significant improvement, then we know that we need to do something else. We modify their program, or we will send them for surgery. The patients that will go now for surgery, they have the IDT support, they have hip-dedicated exercise-based rehabilitation. We develop early plan in collaboration with the surgeon. They have prehabilitation along with education. They have early post-op rehabilitation, and they're coming back to us in a few months' time to improve them and advance them, and then they live with another 3 months program. Physical activity and sports recommended. Those of us that they deal with elite athletes, they know that these people, they need to go back to sport. We prepare them. We have an early plan to go back to sport, and they know when and how. And to return to the military exercises. So this is really important. Now, patients' expectations are extensively discussed. This is something very important that we don't do all the time. And me, as being an orthopedic surgeon as well, I know that the expectations are not discussed in the orthopedic world. So this is very important, and we use the shared decision-making strategy. The patients that have great education about their conditions, they will be ready to face the treatments. They have the knowledge about the risk both surgical and non-surgical treatments, what to expect, the treatment options, and the duration of these treatments. So they know the surgery will not be the magic bullet. Rehabilitation will not be the magic bullet. They will know that we have seen a lot of, diagnostic pathologies, people with no symptoms, for example. These are education strategies that we use. And we monitor the response to treatment, taking the physical impairment, but also the mental and the psychosocial factors to monitor the response. What we use for strength and range of movement, the outcomes, we use the HAGOS and IHO12. But also what is very important for our high demand athletes and soldiers is the GAT-7 and PHQ-9 questionnaire that they will give us impression about their anxiety and depression, and also the psychological readiness to return to play for Christian Thorborg if needed. And we know that it's very important, the psychological readiness to return to sport. Second, RCT systematic reviews, best practice guidelines. We update this, as I said, quite often based to the latest evidence. And as I said, we just published the ESCA consensus, and tomorrow night we have an update in ESCA, so you can join us to learn more about this consensus. Knowing knowledge of the weaknesses and impairments, I know that you have the best people there to do this, so I'm not going to talk a lot about this. But today we have, with all the evidence out there, with all the great books, resources, we're perfect clinicians. We have amazing work has been done, and this is a work has been done back in hospital 10 years ago. We have these clinical entities from Adam Weir and the team, and this fantastic, figure there. And we have the hip joint netless anatomy. We have perfect hip knowledge and illustrations, but are we missing anything? We're great clinicians, but sometimes we still miss things. Are we missing the person behind that hip? At DMRC, we don't. We work a lot with our patients and we listen to them. And why we listen to them? Because we know that a picture from the evidence over there, a picture does not tell a story. We can have a perfect X-ray, but the patient is still symptomatic. So listen to the patients. It's a lot of evidence out there. I'm not going through all the papers, but a picture does not tell a story. So patients' voices and much more. Why is this? We know and we call our patients the culture of the risks. Both in elite athletes and in sport, we know that the greatest fear is to suddenly experience a devastating injury, which for both is cause of a career ending. And you all know what means career ending. We know that this individual can go from high functioning to being ejected by their organization. This will impact them a lot. And their fortune can suddenly be reversed, and their entire life path can change in an instant from an injury. Our athletes, our patients, our soldiers finding themselves outside of their former world, this will change their life. The change is often paired with feeling of devastation, invisibility, loss of identity, and unfortunately, some of you and us, we still support this culture. We say that there's a strong focus on honing the body and mind to make the athlete or the warfighter an effective instrument. And we try with you to change this culture. Why? Because we know that a sports injury in high level is a very stressful health event. is associated with complex risks and consequences and outcomes. Just few examples of psychological issues can be associated with sports injury and illness. Identity loss. Remember, our athletes, our soldiers, they create this identity when they are very young, when they're 13 years old, 14 years old. They know to be soldiers or athletes. If they lose this identity, they don't know what to do. They have fears and anxiety. They lose their confidence, performance decrement, and then the isolations and loneliness comes. So how we approach and how you all approach, but it's nice to remind, the biopsychosocial approach for us is the key. And you will say, well, are you coming to say this 47 years later? John Engel argued that the psychological and social factors can influence the biological functioning and play role in health and illness. And you know this, but 50 years ago, we know that play important role, and because we work very hard at DMRC with that and we see the benefits, I would like to share all this for you. You're familiar with the biopsychol model and approach and what that means, but what that means, if we translate it to their hip, let us see what is the biological factors. Is their body, is their hip, their impairments and their weaknesses? What is the psychological for their hips, their beliefs, the expectations? My hip is going to be damaged with exercise, hence I don't exercise. Will surgery cure me? Is this the end of my career? And the psychological, sociological factors is their world, the sport club, the friends, the peers, the support from the family and the club, how people they feel about them. So, and if I go 80 years almost earlier, you see the definition of health from WHO, state of complete physical, mental, and social well-being, and not merely the absence of infirmity. And it's nice to remind this all the time to the young clinicians. So remember, our patients are not their hip, and some people they are not familiar with the biopsychosocial model. They will ask, but how we do it? And I say that you probably do this, but you don't know it. So to my young trainees, what I say, look at the world through your patient's eyes, walk through the world in your patient's shoes, and then you know that you applied this model. Listening to your patients, they're the most valuable source of information, and the biopsychosocial approach, it is a philosophy of care, and it's a philosophy of great importance. We should not underestimate in our world, in the world of sports medicine and sports injuries and orthopedics. And if you're not familiar how to approach the patient the right way, there are so many papers out there, and this is one of my favorite papers from Carneiro, Ross et al. And they have 5 strategies and a nice roadmap to manage a person with musculoskeletal region. Of what they say, what we do in everyday practice. Always screen for serious pathologies, of course. Embrace patient-centered communication. Listen to them. Ask about their pain experiences, the coping mechanisms, their beliefs, the impact of the pain, the concerns, they believe, the social factor, their goals, short term and long terms, their expectations, and use this information to guide the examination and your management. Educate and educate beyond words using active learning approaches. Not everyone is the same. Embrace education as a central aspect of their care. Um, Write down the information to take it at home. Use behavioral learning and to dispel their beliefs that they're not really helpful. And course to work self-management. Remember, these patients are going home and they're alone. provide them with a plan to help manage the exacerbation, and tailor their care to them. And then access comorbid health factors, refer to co-care, again, integrate with the teams. And even more, there are there's more evidence out there, practices to foster physician presence in the clinic. You can just go and read it. Prepare with intention, make yourself, this patient before they attend to the clinic. Familiarize with yourself, with your patient. You build the trust relationship when they're coming and they say, and you say, you know, I've read all your letters. I went through all your scans, and I know almost everything about you, but now I want to hear from you because you're the most valuable source of information. So don't interrupt, listen to them. Agree what matters the most for them. It's a different what matters for an elite athlete, a soldier, or someone who just has a hip pain and they're okay with analgesia and a good life. Connect with a story and celebrate their successes, the little successes. You will empower them to engage with their treatment, and notice them, listen them. And balance the indicators of the evidence. We are driven by quantitative research, all these numbers, they're very important, and this is the traditional evidence that we follow, the numbers, the computers. But what about the qualitative research, the subjective, the words, what matters for our patients? And again, there is a fantastic evidence out there saying that when we balance the indicator of evidence is so important, and this is from Professor Greenleck, the Paul's supervisor at his important PhD work, which you have to read if you haven't so far. Qualitative research can help us to understand better the complex relations within athlete health protection as a complex system. So we have the social ecological context in which athletes seek and receive care, and how best to influence those involved in athlete health protection for better outcomes. And we follow all that. Why qualitative research matters? There's more evidence why it's important, and the athlete voice, the athlete care, the implementation. So we know the qualitative research provide the insight to the athlete experience that we cannot get from anywhere else. It will give us information about sensitive topics that we cannot see from quantitative research, and tell us why the implementations are not working. And if you want more hip specific, there you go, hip specific. Targeting pain beliefs and coping strategies may provide opportunities for more effective pain management for hip pain. So what we do at the MRC, we revisit and check the balance between the indicators of the evidence. On one hand, we have the traditional methods. Please follow these methods. That's why we work in science, to provide you with objective indicators of evidence, and these consensus statements, systematic reviews, quantitative research, and indicators that we do measure, but also do not underestimate the reality of your patients, of your athletes, the subjective indicators based on what really matters for our athletes, our patients, our soldiers, the psychological factors, their beliefs, their perceptions, the experiences, what they understand, the qualitative research indicators that we cannot measure, but do matter. And I always say, everyone will say, oh, we're so busy now. These are great theories. What is our excuse? This is my waiting list. Honestly, Paul knows that I work 20 hours a day, 7 days a week. In your right, you have a nice picture with for chocolate lovers in the room, the left for the surgeons in the room. I know your practice looks like my practice. But you know what? We can do this. And it's not a new, I'm not the clever person to come here and tell you. Dr. William Osler said all this back in 1849. Listen to your patients. They're telling you the diagnosis and they're the most valuable source of information. The person who studies medicine without books, sales, and uncertainty, but the person who studied medicine without the patients and how they feel does not go to the sea at all. The best preparation for tomorrow is to do today's work well. So be prepared and know your patients. The value of the experience is not seen much, but and seen wisely. And that's why we are here today, and we are sharing our experiences. Tip and tricks, many, but I hope that you can go back and just read that. The interdisciplinary approach is the way ahead when caring for athletes. Engage in teamwork to achieve common goals for your athletes with your athletes. Be aware of the fundamental differences between the interdisciplinary teams and multidisciplinary teams, and stop chipping away at silos if you do it. Make a better use of the team and learn from each other's expertise. The biopsychosocial approach, it is a philosophy of care in sports medicine and beyond. Listen to your patients carefully without interruptions. Ask and listen to their story. You are learning from them so much about them. Patient-centered approach, it's exercise tailored, we know that, but remember that person behind that hip. Discuss patient's expectation and goals. Ask about their coping mechanisms, short-term goals, long-term goals. Dedicate time to educate them. We know that is very important. Educate them beyond words. Work with the staff and make sure that consistency is the key. The messages we deliver across the teams are consistent and the same. We don't want to confuse this patient. Just use simple language and deliver common message. As is over me, no room for egos between the members of the interdisciplinary teams. Be well prepared for the patients because they arrive at the clinic, and inspire them and empower them to engage with their treatment and celebrate their successes. Appreciate the importance of the qualitative research and reserve a big seat at the table of your practice, and ensure that more and high qualitative research is included to your best practice guidelines, which again will be based on the traditional evidence. Provide them individualized plans to help them manage when they are alone at home, to manage their symptoms, exacerbation, progressions, and regressions, what we like to say. The athletes should be part of the decision-making team. We make them part of us, part of our team. One size fits all does not apply in modern medicine in general, and patient-centered approaches require that we embrace, recognize, and integrate the perspectives of the patient, but also the all members of the team and everyone involved in athletes' health protection. But no matter what, be the best advocate of your patients and keep fighting their corners. And again, thank you for your attention.